السلام عليكم.
عليكم السلام ورحمة الله.
يا هلا مرحبا دكتور وليد، كيف حالك؟ عساك بخير. طيب ان شاء الله.
الله يعطيك الصحة والعافية
الله
رب إن شاء
يعافيك
الله.
ويسلمك. معك محمد
الله
الشافعي، ريجنال سيلز مانجر شركة برينجر هاي.
حياك الله. حيا
الله
دكتور.
يحييك يا حبيبي. انا قلت بس ادخل امسي عليك واسلم عليك وان شاء الله تكون امورك باذن الله خير.
بارك الله فيك، يعطيك العافية وكل عام
الله
وانتم بخير
يسلمك
جميعا.
ويعافيك حبيبي دكتور، وانت بخير والصحة والسلامة. الله يعطيك العافية دكتور.
جزاك الله خير، شكرا.
الله يسلمك.
طيب دكتور، أتوقع في عدد كويس الآن من الدكاترة. Thank you للناس اللي already joining our meeting دكتور. Today إن شاء الله we will have a presentation presented by Prof. Walid Al-Bakr. He is a Chief Medical Officer of Academic Medical City Department of Endocrinology at King Fahd University, and also he's a consultant endocrinologist at Dalla Hospital. And doctor has many publications, mashallah, tabarakallah. So Dr. Walid, the floor is yours, doctor.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله عليه أشرف الصلاة والتسليم. Thank you very much for nice introduction. Thank you all for joining us this night, and I hope the coordinator allow any speaker waiting, any guest waiting to enter to the lecture at any time. So just to track those who are the guests. So today, actually, I'm going to talk about very interesting topic, and it touch actually many system, which is about cardiovascular, renal, and metabolic condition, and using mainly empagliflozin, and by reducing the risk of for people with CKD, CHF, and or type 2 diabetes. Next, please. So let's start with the principle. A lot of people talk about the CRM system. And CRM system is a new terminology that we heard lately in a lot of diabetes conferences and meeting and scientific meeting, that people now think of when they treat diabetes in these three actually important area: cardiac protection, renal protection, and metabolic protection. So the cardiac, where the heart is most a metabolically demanding organ and susceptible to changes in volume and metabolism. And the kidney, which play a major part also in the glucose and the volume homeostasis and blood pressure regulation. On the other side, that also there's regulation actually of energy metabolism by liver, pancreas, and fat is essential for healthy function of organ, especially in heart and kidneys. Next. Next, please. So when you look for the cardiovascular, renal, and metabolic condition, it usually poses a very high disease burden globally. And we know that almost there's 850 million people with CKD. There is more than 530 million people with type 2 diabetes, and more than 60 million people with actually heart failure. So approximately 50% of people diagnosed with heart failure will die within 5 years of diagnosis. And estimated global prevalence of CKD is more than 11%. And CKD is asymptomatic, unfortunately, in its early stages, which contribute to the low awareness of the disease in people with CKD and a clinician. And the prevalence of type 2 diabetes is high and rising across all regions. Is my voice clear now?
Very clear.
Yes, I hear the sound. Okay, excellent. So, and there is a large unmet need in the heart failure and secrecy of approved therapies in some forms of heart failure. Okay, next. So when you look for, again, part of the cardiovascular, renal, and metabolic condition frequently coexist because they are interrelated. So do you know that up to 40% of people with type 2 diabetes, they have already CKD, and up to 60% of people with CKD have established cardiovascular disease, and 30 to 40% of patients with heart failure, they have CKD, and 16% of people with heart failure have both comorbid of type 2 diabetes and CKD, and 20 to 40% of people with heart failure have type 2 diabetes. And approximately 1 in 3 people with type 2 diabetes, they have cardiovascular disease. So tell us that there is actually a big correlation between type 2 diabetes and, of course, the existence of the renal, the CKD, as well as the cardiovascular and the heart failure. So that's why it's important actually to consider that when you approach impaired diabetes, you look to the 3 areas of cardiac, renal, and metabolic. Next. So the life expectancy is reduced by almost 12 years in diabetes patient with a previous cardiovascular disease. So modeling of the years of life lost by the disease at a status participant at baseline compared with these free of diabetes, you can see clearly how the survival or life expectancy reduced when you have diabetes with MI by 12 years, and we have diabetes alone by 6 years, and we have no diabetes, it's like good, with a normal lifespan. So this is important. That's why when we target diabetes, we're not targeting only the A1C, we are targeting also a medication that have a survival benefit in mortality and morbidity level. Next, please. So the interconnected nature of cardiovascular, renal, metabolic disease amplify the risk and accelerate the progression. So any one of these interrelation between these 3 things, it can accelerate the progression across the cardiovascular, renal, and metabolic. And the cardiovascular, renal, metabolic, or CRM, have a few, if any, specific symptoms in early stage, but ultimately it results in increased risk of complication, including even cardiovascular death. Why we are saying that? Because early intervention is the best way to help protect patients by reducing the risk associated with these conditions. And this is emphasized the importance of early intervention in the treatment of diabetes early to prevent all these complications and improve mortality. Next. So look into the ADA guideline 2026, looking for glucose lowering medication algorithm, and you can see there's a big emphasis of the SGLT2 inhibitors in the actual algorithm. If you compare it to 10 years ago, which is almost not existing, now it's very actually well solid medication that must be used in those patients with renal problem and or cardiovascular problem. Next. Next. Next please.
بس معاك يا دكتور، بس انه معلق معي دقيقة.
So till we get that one, now I just would like that the SGLT2 inhibitors, we will talk actually now in a lot of studies and evidence it show the benefit of this medication at the level of cardiovascular and at the level of the renal, and why, based on this evidence, why this medication is hugely integrated in the algorithm of the ADA and the ASAT also. And in fact, if you look for the SGLT2 inhibitor, it reduced the A1C by only 0.6% to 0.7%, which is a minor reduction of A1C. But if you look to the impact of this medication on the cardiovascular mortality and morbidity is hugely high, which seems that this medication, it works by a mechanism even beyond actually the glycemia. It works beyond the glycemia. It works toward actually something at the cellular level, which I will show it now, the mechanism of action of SGL2. Next, please.
يبدو نفس المشكلة يا دكتور، في مشكلة بالسلايد الثامن إنه نفس الشيء كل ما يجي السلايد الثامن يرجع.
Okay, you can skip it. It's 8-1.
Yes.
Skip it. Okay, skip to 9. So just to save time, as I mentioned, that the SGL2 inhibitors, it work at the level of a cellular level beyond the glycemia, and you will see that in the result actually of the SGL2, the level of the kidney and the level of the cardiovascular, and because it affects the hemodynamics and the blood pressure and the volume expansion, not only the glycemia. So this means that SGL2 is just like beta blockers and ACE inhibitors in heart failure, and also just like ACE inhibitors in patients with diabetic nephropathy. Okay, next. I think there's a problem. The slide is stuck in 7.
Also 7? Does it change on my side? So تمام دكتور، خليني أجل أشير الشاشة نفسها بدل البرزنتيشن.
Sorry about that. We'll continue now. Don't worry. I will just promise to be on time, and we'll make sure that now we'll go to the interesting part about the mechanism of SGL2 and all the studies at the level of cardiac and renal, and then we'll talk about a combination of this medication with the DPP4 inhibitor that available in the market, and the study behind that one that show the efficacy and safety of this medication, and also the benefit of this medication compared to the other actually medication available in the market. So I hope it's clear, the slide, if you can confirm with you the chat. I hope it's clear, everybody. Now, it's for me, it's clear now. And now I'm going to talk about addressing the metabolic consideration in the context of CRM. If we look for SGL2 inhibitors, it facilitates the renal excretion of excess glucose through the insulin independent mode of action. So it helps in diuresis, it helps in glucose excretion and natriuresis. And that actually somehow it affects on the hemodynamics and the volume expansions. Next, please. So if you look for the empagliflozin in particular, it provides a triple protection by reducing the risk for a broad range of your patient. So you can see that almost there's a 38% relative risk reduction in cardiovascular death, 32% in all-cause mortality reduction. This is at the level of type 2 diabetes and cardiovascular disease. How about extreme right here, CKD? If we have only CKD with EMBA, do you know that in non-diabetic, it can reduce by 28%. So it actually relative risk reduction in kidney disease, a progression, or CV death. And if the patient having heart failure, this is the one in the middle, heart failure, in non-diabetic even, actually in both, whether you have a preserved ejection fraction or reduced ejection fraction, which make SGL2 empagliflozin unique in both preserved as well as in reduced ejection fraction, both the relative risk reduction of cardiovascular death is reduced by 25 and then 21%. So empagliflozin provide a metabolic benefit in type 2 diabetes, including also reduction in A1C, systolic blood pressures, and weight. This medication even in non-diabetic patient, in heart failure and CKD, it's also show benefit. And its benefit is actually almost equivalent to the beta blockers and ACE inhibitors in heart failure and also kidney disease. So this medication work beyond actually the A1C. Next, please. So empagliflozin is easy to use across a broad range of people with CKD, heart failure, or type 2 diabetes. So it actually can be taken anytime, so to work every 24 hours, easy to store and administer with or even without food, no titrations required. And the dose we use is 10 milligram in those actually in heart failure or CKD, Jardiance or empagliflozin can be initiated even down to GFR of 20. Yani we can actually use it even if the GFR go to 20. For people with type 2 diabetes and CV disease or cardiovascular disease and have type 2 diabetes, then it can actually be initiated down to 30 ml for this patient. So no titration required for most patients. Next, please. If we look for empagliflozin, it can be initiated with a GFR as low as a 20. This according to the latest guideline in people with heart failure or CKD, and that is give us a good range. So we can see that this graph it show you the first one to reduce the risk of kidney disease progression or cardiovascular disease in adult with CKD with or without type 2 diabetes. Actually, you can use the GFR of a 20, more than 20. To improve glycemic control in adult with type 2 diabetes, GFR more than 60. To reduce the risk of cardiovascular death in patients with type 2 diabetes and CVD, if GFR more than 30 and no dose requirement. And to reduce the risk of cardiovascular disease and heart failure in adult with heart failure, more than 20 and no dose adjustment. So next. So what I would like to say here also, next please. Let's talk now about, this is my first part of talking about the empagliflozin, and now I'm going to talk about linagliptin, which is marketed as Trajenta. Linagliptin has a proven efficacy, is one of the DPP4 inhibitor, and pooled analysis of a 24 weeks phase 3 trial, randomized trial, can drive placebo-corrected reduction of 0.8% in A1C. So it actually, this against a placebo. Next. And the Trajenta itself is extricated in via non-kidney route. وبالتالي, this is not all DPP4 inhibitors are the same. About 5% of the Trajenta only exit in the kidney, and that's why it's very safe in patients actually with kidney failure. Next. So there's two studies, one called Carolina and Carolina, and this is together from a comprehensive CVOT program. And both it demonstrated the long-term safety profile of the Trajenta in a broad range of patients with type 2 diabetes. Next. It showed that time to first occurrence of albuminuria progression, there is actually delayed in the progression to albuminuria by 14% relative risk reduction. So the Trajenta, not only it's safe in renal failure, but also it reduced the progression of albuminuria. This is based off the Carolina trial. Next. Another side, actually, that how about if we combine Jardiance, which is empagliflozin, with linagliptin, which is a Trajenta, as a combinations called a Clexembi, which is a combination between empagliflozin and linagliptin. You can see this is a powerful mean A1C reduction of 1.8% in patient with baseline more than 8.5. So this is really good. When you have a patient who have A1C of 8.5 and you give only one tablet of combination of these two medication of Clexembi, it can reduce the A1C by 1.8% of a dose 5 over 25, 5 for Trajenta and 25 of the empagliflozin. So that's really without any additional without any additional medication, and it is usually with no GI side effect, with very effective A1C and very excellent for the kidney, and also have a cardiovascular benefit through the empagliflozin. And remember, the linagliptin, it's safe in the cardiovascular but not superior. So the cardiovascular benefit of this combination is because of empagliflozin, and both of them, empagliflozin and linagliptin, both are effective in level of the kidney full albuminuria, and it is one tablet sustained taken once and excellent for compliance, and also reduced by 1.8% with no GI side effect. And also, if you look for a significant reduction versus each component alone, you can see this is a complete the combination. With one tablet, you can have additional A1C reduction. If you have a patient who have taken Jardiance, for example, you can shift them to Cleximbi. You can have additional actual A1C reduction with the same tablet, one tablet. Next, please. So single pill combination treatment offer several advantages. It's changed the medication adherence in subject receiving dual therapy in the pre-index, as you see it here. And also we look for, this is the change in A1C, single versus a free. Of course, it actually toward better for the combination. Next. So adherence and efficacy in type 2 diabetes, empagliflozin and linagliptin combination, it provides a treatment in one to help patients stay on therapy. So it basically increase adherence. So it's associated with a greater efficacy. The patient will take one tablet with better efficacy. So it improves adherence by 10%. This has been shown to reduce A1C by additional 0.1% compared with non-adherent. يعني الcombination عملت more adherence compared to if it is separated. يعني تاخذ الجارجس لحاله والليناgliptin لوحده. So if we put it together, you have additional reduction by 0.1% because improvement of adherence by 10%. Also, it may promote poor adherence is associated with higher cost and mortality and hospitalization rate. Either each 10% increase on adherence associated with a decrease 0.1% in A1C. Very interesting study show the importance of adherence and the relation with A1C. Next, please. So in patient with type, can you please mute, please? Can you please mute? Please, can you mute?
وانا بقى من شهرين ايام تحديث السنه كانت امتى؟ في يناير، ودايما يحصل مشاكل في يناير. كان عدى سنه فخدته طلعت كلمت الدكتور، خدته طلعت على الدكتور.
Okay, thank you. So back again, please. Thank you. So back again, now in patient with type 2 diabetes with high cardiovascular risk, empagliflozin and linagliptin contain empagliflozin to provide also reduction in a new onset of macroalbuminuria. And you can see there's a reduction, 38% of relative risk reduction of a new onset of macroalbuminuria. Excellent. So this means the combination, EMBA and LINA, both have a good benefit. Now, other thing, in patient with type 2, طبعا additional benefit, يعني كلاهما empagliflozin as well as linagliptin both have reduction in a new onset or worsening of nephropathy by also 39%. Next. Not only that, in this combination also provide a reduction in doubling of the serum creatinine with GFR less than 45 by 44%, a relative reduction in doubling of serum creatinine. So we have a medication that's really targeting the CRM, cardiovascular reductions through the empagliflozin arm, and renal protection by both empagliflozin and linagliptin, and of course, in the metabolic part, by controlling the A1C by 1.8% reduction as a combination, and better adherence with this GI side effect, or no side effect of GI, and it's long acting with one pill. So this is really a good advantage for this such combination. Next. And I want to tell you also, even the combination, it provides reduction time to first initiation of the continuous replacement therapy by 55%. And this is really very impressive number. And I wanted to bring your attention, all the data brings at the graph. You can see there is early benefit of these medication from the beginning. Immediately you can see separate actually of the lines early in the first few weeks, which tell you that this medication, it works at the cellular level beyond actually the glycemia, and it has an early benefit. So early intervention is the key actually that prevent long-term complication. Next. So for patients with type 2 diabetes who need additional glycemic control, empagliflozin and linagliptin as a single tablet, you can see on the left side, the small tablet is the tablet of the Clexembi. It's very small one. The Clexembi is really very small one, so easy to swallow. However, if you look for other combination in the market, you can see one single dose is really big. So again, this is, I'm sure you face a lot of combination tablet is really big, and this tablet actually is really small and easy to swallow. So make the patient also comfortable to deal with such medication. For patients with type 2 diabetes also, this combination provides two treatments in one to help patients stay on the therapy. One, because of the single tablet. Second, because of it is a small size tablet that increase adherence with which result, of course, in a greater efficacy. I have very excellent experience with such medication like that. For حتى الإنسان patient he avoid taking many tablet, just one tablet. Psychologically he feel better. It's a small one and do the job and do really a good benefit at the level of the cardiac and renal. Next. طبعا empagliflozin and metformin, which is the Synjardy, or combination of empagliflozin and metformin, it comes in different combination. We have 12.5 over 850 BID, or there is 12.5 over 1000 BID, and there's different combination in the market. And you can see actually that how the reduction of A1C is really impressive, of less than 2.1 it go if you combine empagliflozin with metformin. Again, it's very excellent combination, and you can actually have additional 24 weeks extension, additional reduction for A1C to 4.6. So it's actually really very impressive a drug with a good cardiorenal protection. And so up to 70% of the patient can achieve A1C in target. Next. So a percentage of patient with more than 5% reduction in the weight at week 24 in randomized trial, it can show you that combination of empagliflozin and metformin, both it can reduce the weight, and it can show you actually that almost in the combination اللي تكون 12.5 over 1000 BID, it can actually 40%, تقريبا قريب النص of them, they achieve more than 5% reduction in their weight. So reduction of the weight is really good, and it should be one of your considerations, especially if the patient having underlying MASH or fatty liver. And a lot of actual studies, and if you look to the recent guideline, you can see the SGLT2 inhibitors, it's actually play part actually in the MASH treatment. So weight reduction is important actually also at the level of the liver and fatty liver disease. Next. So if we look for the combination, so we talk about the first combination, which is empagliflozin and linagliptin with the name of code Clexembi. Now, this is the other combination of empagliflozin and a glucophage with different combination as you see it in the screen. This combined safety which will allow to individualize patient treatment with different dosing. طبعا إذا كان إنسان you can use it. Some patients they might have some يعني يعني for certain reason you want to having dizziness or polyuria or kind of incontinence, you can adjust actually the dose of the SGLT2 inhibitors. Or if the patient having some GI side effect, you can actually reduce actually the glucophage or the metformin. So you can actually play it depend on your patient's side effect. And this is in general have a good safety profile. Next. So SGLT2 trials in patient with CKD disease, we have actually the IMBA kidney, which is enrolled a broad population of CKD. وهذا ما يميز حقيقة الإمباgliflozin compared to the other DPP4 inhibitors that in IMBA kidney trial, they include, as you see it in the red box, they include a large actually population of CKD compared to DABA and other medication. The trials which use of SGLT2 inhibitor kidney disease, we have the Credence trial, and we have the DABA CKD trial, and IMBA kidney trial. And IMBA kidney trial, what actually excellent about it, it includes very broad range actually of CKD population in low, moderate, and high risk, and very high risk. Next. So let me just challenge you in this questions. I mean, this is Sultan. He has been diagnosed with CKD and is at increased risk of cardiovascular, renal, and metabolic conditions. He has hypertension. He has dyslipidemia. He had family history of CKD, cardiovascular disease. He's in ACE inhibitors, statin. He had GFR 68, albuminuria. So, and basically, he have diabetes and have all of these combinations. So this is, if you look for this circle, CKD risk factors is well known. Diabetes, dyslipidemia, hypertension, obesity, tobacco use, age is high. This is the risk factors. And this is our patient. Next. And next, please. So how would you reduce the risk of cardiovascular, renal, and metabolic to help Mr. Sultan? One, reduce the risk of cardiovascular and metabolic conditions should be a patient top priority. So احنا مو فقط we will just targeting the A1C, but also we need actually to decrease all this complication. So we need to discuss the importance again of what? Of early, very important, 2 lines under early. With the multifactorial approach for improving long-term outcome is the key. So shared decision making, open discussion with the patient, integrate medical consideration and patient preference also, and see the patient characteristics, and it can improve the treatment adherence. How will treatment impact my day-to-day life? Is it important it does not affect my traveling or work? Or مثلا يقول لك والله I work long hours, or I need to take medication that's easy to take, or I would hate to end up needing dialysis. يعني it is actually you need to discuss with the patient, see if he has GI side effect, if he has urinary problem, if he has a prostate problem, if he has a problem with urination, if he has a problem with GI side effect. كل هذه الأشياء we actually put it together. If you have a previous heart failure, if you have a previous, for example, MI, if you have an evidence of already diabetic nephropathy, all of these things, it helps you to find what the best medication to give to your patient. A businessman who is traveling a lot, have a lot of conferences, he needs something really flexible. One tablet can do the job at any time, not related to the food. You can take it, it can do the work. So this is again very important, and again you take the case by case, and it depends on your patient characteristic, and that's the recommendation for all the guideline now is to move from A1C centered approach to a patient centered approach, and this is how you select your medication. And as you see it in the ADA guideline in 2026, now metformin is not anymore your first therapy to be started and to be added. No, you need to look to the patient characteristic, and based on that, you choose your medication. And again, A1C target, if it is in target, doesn't mean that you should not change the medication. You can change the medication if you are aiming to have a cardio or renal protection. Next. So early diagnosis intervention CKD is crucial for patients with known risk factors, and early screening diagnosis CKD is important. So determine known risk factors and screen regularly by UACR and GFR, and the tests provide the evidence needed for early diagnosis. Next. So in people with type 2 diabetes at high risk of cardiovascular, rate of kidney function decline after the initial decrease was consistently slower with the patient taking empagliflozin compared to the placebo, very clearly there. And we think that this is due to hemodynamic mechanism of action that cause initial reduction of the GFR. You can see it in the beginning, that it can happen and you can expect it in the first, but later on it gets better and it shows there's a slower actual reduction. So yes, in empagliflozin you can find mean GFR later, it gets stabilized. يعني في البداية it might actually cause some initial reduction for GFR, and then second stage you might get mean GFR stabilized after initial drop. بعدها GFR decline was slower in Georgia's group compared with a placebo. It actually changed the curve. You can see it, the one in red and blue. And then GFR rebound after a drug discontinuation was observed with the Georgias, indicate a reversal of the renal hemodynamic effect. So this is not related to the blood sugars, it is to the hemodynamic effect that you see it in the kidney. And this is what they actually find it in the IMBA-RIG trial, one of the first studies done on the SGL2 and 12 CVOT trial. Next. So if you compare IMBA and dapagliflozin, you can see that in cardiovascular reductions, well, we have actually in both in empagliflozin and DABA. Sorry for that. I mean, even DABA, we have cardiovascular death reduction, but in fact, actually, EMBA, it actually show a really big number. Kidney study population is due to wider range of patient compared to DABA, and combination tablet size is 8 millimeters for the EMBA compared to DABA, which is 21 millimeters. Next. So, I think to improve the quality of our patient, it's important actually to choose a medication that improve adherence, single tablet, a small one, taken once, have a great benefit and a great result, and excellent reduction in the A1C, as well as in the weight. And in fact, this medication is very safe in terms of hypoglycemia. I was involved in actually consensus statement that we did in dapagliflozin and other SGL2 inhibitors in Ramadan, and we found also SGL2 inhibitor is very safe actually in fasting in Ramadan. So because the risk of hypoglycemia is extremely actually low. So we have a medication which is very low hypoglycemia, excellent weight reduction. Combination can have excellent A1C reduction, safe and in cardiovascular and maybe even reduction cardiovascular death and mortality and morbidity, and also in heart failure, as well as actually very excellent in nephropathy, and indirectly it affects on the fatty liver. So and this is really approach going with the recommendations of all guidelines, which is recently published in ADA. So with that, I conclude, and thank you very much, and ready for any question.
Thank you, Dr. Walid, for informative lecture.
I think there's a question. Do you want me to read it and answer it?
If you want to, Doctor, and if you want to, أنا أقراها ما عندي مشكلة.
Sure. Go ahead, no problem.
Okay, so for Dr. Rehab question, which dose of Synjardy do you recommend to start for diabetic patients?
So basically, if the patient having a lot of GI side effect, I might start with 850. But if the patient having no GI side effect, no IBS or reflux, and A1C is a little bit high, above 8.5, so I go with Synjardy 1000 BID. It should be okay taken with meals. So I should be okay with that one.
Thank you, Doctor. And for Dr. Yasser, he asked about when can we initiate EMBA for CKD without diabetes at any stage? And is it same DABA when it comes to label?
So when can I initiate IMBA for CKD without diabetes? Well, as I mentioned, طبعا احنا up to GFR of 20, we can actually take empagliflozin. I mean, less than that, the delivery of the SGL2 will not be effective if it is less than 20, but we can initiate it. And putting in mind, as I said, where you see sometime initial drop and then it correct later because of the hemodynamic. So GFR above 20. And is it same DABA when it comes to label? Yes, it's almost same now. Yes.
Okay, Doctor. For Dr. Muhammad Zannan, he said any difference in cardiovascular and renal positive effect between the two doses of Jardians, 10 and 25?
For basically in patient with diabetes, so I use actually, I mean, diabetes with kidney disease or cardiovascular, I use the dose of 25. But in patient without diabetes, just for heart failure or just with a kidney problem, you might use the smaller dose of 10 milligram.
Thank you, Doctor. Can we use, Dr. Khaldun questioned, can we use it in obesity patient with pre-diabetes to control body weight and not to develop diabetes?
So as you know that it can affect, but usually, as you know, the SGL2, if the blood sugar go above 180 in the blood, it start causing diuresis. So if they are in a pre-diabetes, usually they don't reach that number. So maybe it's not that effective in a pre-diabetes range. So I don't think that it will help much in such case. But if you use it in combination with GLP, it might, in type 2 diabetes, not in a pre-diabetes, type 2 diabetes, it will do a good job.
Thank you, Doctor. For Dr. Jihan, she asked about the cut limit of EGFR to start SGLT2 inhibitor.
So as I mentioned that, if you look for 3-4 years ago, it was 30, then they drop it to 25, and now to 20. And correct me if there is any from your side, Shabab, but I think above 20.
Yes, it's true, Doctor. And Doctor, allow me to ask the guests if anyone has a question. It's okay to unmute yourself and ask Dr. Walid. So, Doctor, thank you for your time. If you have any additional word or speech, free Dr. Walid to say it. Yani. It was a very informative lecture and has many also questions from doctors. Thank you, doctors, also to participate in this presentation from Dr. Walid.
Well, I would like to thank you all. So I and really I see really a very effective result on my patient, and I think this is an excellent addition in the pharmacy list you have.
Thank you, Doctor. Hopefully, inshallah, in next days, أول شيء اللهم أدم علينا الأمن والأمان. Next, inshallah, meeting will be بإذن الله يكون physical سواء من ناحيتك دكتور أو حتى من ناحية الجيست. وتكون الدسكشن فيها أكبر وأعمق بإذن الله. Thank you for the guest also. So we come to an end. Inshallah, we will see you in next lectures.
Thank you very much. يعطيكم العافية.
الله يعطيك العافية يا دكتور. Thank you. Thank you.
Thank you, Dr. Walid.